we are going to bring Dr. Shah on, and as I mentioned before, Dr. Shah was with Dr. Edmond at the 2018 conference and performed all those eye exams, and that's where we first met Dr. Shah, and we're so grateful to have him on board. He is, it's a long list, so let's see. Oh, goodness. And I don't have it, so you know what? I'm going to let you.
Let me go.
Let you go. But this is the wonderful, talented Dr. Shah, and all I know and what's most important to me is that he is on our scientific advisory board as well for the NR2F1 Foundation. So welcome, Dr. Shah.
All right, guys. Hi. I'm going to second what you said. I'm just really impressed, and I'm excited to be here to see all you people, some people that I know really well, and yeah, oh, thank you. And it really, it's inspirational to see everybody, even, as you mentioned, the kids. I'm surprised the kids are doing so well, so, and all the caretakers for watching them. So I want to thank you for inviting me to speak, and I'm honored. My talk is on something that people have already started asking me questions about, but it's cerebral visual impairment. There are many names for this, as Dr. Edmond had mentioned, brain-based visual impairment. There's cortical visual impairment, which is the traditional term. The more consistent term, I think, that moving forward with both the European colleagues as well as in American colleagues, looks like cerebral visual impairment is where I'm going to use that today. I have no financial disclosures, and I'm going to tell you one more thing. So there's something here. The other two lectures were virtual. This one's live, so I'm really grateful for it because it's been a while since I've given a live lecture because we've been doing virtual lectures for a long time, or for the last 2 years, I should say. But in this case, I don't have a screen here that's connected, so I'm going to change it here. So if you see me look over, I'm going to look over and make sure that this slide is that slide, and I sort of need my slides because there's data here that I want to talk about. So there we go, no financial disclosures. And so this is a picture I think is very useful to understand what I do. So I'm a pediatric neuro-ophthalmologist, and I'm at Cincinnati Children's Hospital. So we're ophthalmologists, vision therapists, optometrists, feel good about the eye. They feel very uncomfortable about what's going on behind the eye. And then neurologists, who are awesome at understanding what's going on in the brain, feel very uncomfortable about what's going on in the eye. So I sort of live in this interface here, and I don't have an arrow, but it's like right behind there where they're being connected, and this is what I do. So it's in a very unique place, but we get to see a lot of interesting things. And so one that has come up, and I'm going to talk to you about primarily for this discussion, is the cerebral visual impairment. So as Dr. Edmond had so concisely put in her presentation, cerebral visual impairment is a visual processing, and I got to change my screen. I got to see, I already forgot. Somebody's got to tell me that. If you start hearing me talk something outside this. So it's a visual processing issue. So it's an impairment of how you process visual information. So the traditional thought process is that the eye sees, the vision is coming to the back of the retina, it's focused onto the retina, back of the retina, sent down the optic nerve, goes back to the brain fine. But what the brain does with that information is where the error is. So it's getting the visual input, but how it processes it and how it wants to interact with it is the processing issue. And so traditionally it's been demonstrated, simplified into a dorsal pathway and a ventral pathway. And a dorsal pathway is sort of the where involving motion and spatial information, and the ventral is a what, it's sort of recognition of object and form that it sees. So as both Dr. Schraff and Dr. Edmond had talked about, what's really clear with the NR2F1 gene is that both optic nerve development is affected and cortical development is affected. And traditionally, when I see a patient that's being either referred in or the visual behavior is consistent with a cerebral visual impairment or CVI, their background is quite heterogeneous in the sense that the etiologies or what causes it can be really varied, and so we have to really search for it. And imaging helps, screening helps, and their eye exam is so important. Where this is so relevant to you guys and everyone here is this idea that traditionally CVI was a normal eye exam and really the visual behavior is inconsistent with the normal eye exam. We know that not to be true. That's just not true anymore. That is true for certain cases, I should say. I should take that back. It's true for certain cases, but what we know is that you can have a global effect where you are having optic nerve development, or what we call anterior visual pathway being affected, and having cortical visual impairment, so a posterior part. And so this is more talking about the anterior visual pathway. So when we see optic nerve and atrophy and pallor, hypoplasia, we're really talking about the anterior visual pathway. And then when we're talking about CVI, we're really talking about posterior processing. However, most cases that I see in our neuro-ophthalmology clinic are a combination of both. That we do see pallor many times, especially on really global issues, and we're seeing processing issues. And what's interesting is in the NR2F1 is really to tease that, which is what. And that can be complex because the spectrum is so varied. So, to get at, I'm going to talk to you about more about CVI, I think, in general. So I'm taking a step back so we get a better idea and of what CVI is, because it's really hard, and I think that's why you saw with Dr. Schraff's initial presentation where he said 14 years to diagnose CVI. I mean, that's late, that's really late. And so we're seeing, I was seeing a lot of these patients and I had a lot of questions, like in terms of seizure, medications, how is this affecting their visual assessment, how was neuroimaging involved in thinking about CVI, and then also what are the long-term effects, right? It's really hard because there's no validated clinical exam to really gauge CVI, and how do we know if any of the therapies that we're doing at the moment, interventions, are going to help or benefit these patients? So I went ahead and put together with two great fellows. I'm going to in the neurology department. So this is not, it's a the team that I had that was great. And they did a chart review of pediatric CVI patients. We got 249. That's a large cohort, and that's going back and looking at neuroimaging, neurology exams, and vision exams, and many of them were neuro-ophthalmology exams. So we looked at 249 at presentation, and we had follow-up data, longitudinal data, for 1 year and 3 years. And we looked at a lot of factors that we thought were important and to characterize predictors for vision prognosis for CVI. So we looked at perinatal, prematurity, we looked at epilepsy history, looking at medication, how does that affect your vision assessment and your exam. We looked at genetics, how many of them were genetics. So this is looking at a reverse. You're coming knowing the genetics, but in the vice versa scenario, when we're seeing vision, a diagnosis of cortical visual impairment, should we be testing for a particular gene? So the genetics was important to look at. Neurodevelopment, neuroimaging findings, and fundoscopic findings. And then overall, we wanted to know, of these patients who got therapy, who actually saw a benefit at 1 year or 3 years. So obviously there's no established validated exam for CVI at the moment. I think a lot of people are working on this, from vision therapists to optometry to ophthalmologists to neurologists. And so I think people are working on it and trying to figure out a way to really validate it. What we did was we had to sort of be creative about devising a grading scale. And we based the grading scale for us on what we could get on their exam from a standard vision exam in terms of visual acuity. So no blink to light, fixate to follow. Okay, and drum, was there a subjective response, meaning were they able to tell us they could see figures or define a shape? These are a young age group that we're looking at. And so we sort of gave them grouped them into categories. And then we looked at these predictors that I mentioned in the previous slide. The mean age of the group, like I said, was young. It's 19 months, but it ranged anywhere from 2 to 108 months in terms of the range. Baseline vision exam revealed no blink to light in about 25% of the children, and only blink to light in 35%, and fixation in about 27% of these patients. Okay and drum response, you may hear that as the black and white contrast lines where they actually, your eyes have a reflex that you have early in life. It tells us sort of an objective standard of their vision, was also noted in about 14% of these. At baseline, at diagnosis, 82% had global delay, 60% had CP, and 78% had epilepsy. In the case, and I want to make this clear, this study looked at it from a tertiary hospital, a children's hospital. Probably a lot of referrals, a lot of more complicated cases that we saw, right? And so a lot of our group was moderate to severe CVI, as opposed to milder forms of CVI. And I just want to color that because I think there's going to be a range that we're going to see as we sort of define this with the NR2F1 gene. So perinatal history was important. This is a graph, and I'm not moving, am I? I'm back here. There we go. Perinatal history was, this is a graph showing the 249 on initial presentation. It's a lot of numbers, so I'm going to move past this. But I want to give you sort of the crux of those numbers, showing that 35% of them had prematurity, 21% of those 35% had hypoxic ischemic encephalopathy. Interventricular hemorrhage was there for 25%, and 21% had ROP. What I think was really most important, and I sort of highlighted in the slides, because I know it's very number intensive, but sort of the take home for some of these slides. Neonatal seizures in presentation in 21% of them, 95% of them ended up developing epilepsy if they had it in that early presentation. So I think that's an indicator for prognosis. So seizure history was really important, and I think as a neuro-ophthalmologist and an ophthalmologist where we're testing and looking at visual exam and assessing these patients, it's so important to understand what you're getting in that time of the exam. There was a question earlier about what can I do to, I think that question was, what can you give to maybe your ophthalmologist, him or her, about understanding what they're seeing. But I also thought maybe the other part of that was what can you do to make sure they capture a full exam or catching it. And whenever I have an office visit, I can only get what they can give me, type deal, and I think many of you know that, right? So it's a first visit always, and I'm very honest about what I can get and what I can't, and I think I've been pretty successful getting what I need to get out of it, at least look at the nerve, but we can only get what they give us, and then that means we do it a second time, right? We do the rodeo again, right? But it's really important to understand when you get that history, the medical history. What it was really clear to me was that of the 249 CVI patients, 195 of them actually had seizure history or epilepsy history. That's a high. That's a really that's 78%, 79%. And what was really clear, which was very significant, that if you were on multiple medications, anti-seizure medications, that you didn't perform as well on the exam. So that I can speak to that because I've definitely seen it just in the room with family, with kids with epilepsy and saying, you know, we just gave them a dose of something there, or they just changed medication, and this is not normal, what I'm seeing there at that time. So I think that really colors when they get that assessment, or if they go for a CVI assessment, which people are clinically trying to put together, you know, some level of assessing their vision, that to understand that if they're on multiple seizure medications, it might not be it might be underestimating what they can really see, right? That was that slide. So that's what I was just talking about. This is this slide, which is just a characterization of the epilepsy. And what we also know is that when you're uncontrolled, when you're having seizures, and I'm speaking to this because we know that seizures are associated with the NR2F1 that gene, that if it's uncontrolled, you don't do as well on your vision exam as well. And so that should also color it. So you know that if you have history of seizures or epilepsy, when you get that control, it's a different situation, different point in development, different point and what you can get in that exam. And so that really colors it. So neuroimaging. So Dr. Edmond and the patients that Dr. Edmond and I saw, and what she presented with the recent finding with the mesial temporal dysgyri, that is really a key finding, and I think really talks about how neuroimaging, because many of those, you know, I remember getting that information and getting it to our neuroradiologist, but I think many of those reads did not pick that up, right? I think it was missed, right, in terms of the dysgyri. And so neuroimaging really has come a long way, and there are newer sequences out, and we have a number of protocols where we're trying to do different sequences to really identify techniques about structure and function. And so when we looked at these 249 patients, 93% of them had abnormalities of neuroimaging. So what we're finding out is that that the neuroimaging is showing us a reflection of potentially what areas of CVI, what areas in terms of cortical, dorsal, or ventral stream may be affected, and really correlating that in terms of prognosis. And then of the 249, these are just CVI patients, about 28% of them had genetic issues. And then, let me go this here. And so that was that last slide I was just talking about. And then this is the slide really just showing you that when you have metabolic or genetic issues, you can have a lower CVI grade as well. And so lower the grade means lower the vision potential, but and higher the grade means you have a better vision potential. So, but this again is all genetics. So these are some genes that are much more severe, and so that's why I think that number is low. So taking this from the view of CVI and not from knowing a gene, it really talks about what genes could we identify, and we were able to put together a panel of genes that are associated with CVI. And one of our thoughts was, if we start to get the genes and put them in a panel, maybe we could get a panel for when we see some of this visual behavior, and screen that way. And that might be a way to pick up the NR2F1 gene in patients. And so a couple of these numbers that are next to it, like LS1, and you know, they're showing that there are multiple. Thank you. So I think there it is. This is the panel of genes that we were able to demonstrate from our cohort, and I think that's it hasn't been, CVI isn't looked upon that way. There are many known diseases, neurological diseases, and CVI is mentioned as an afterthought a little bit, in the sense that, oh, they have all these issues. Oh, and CVI, they probably have CVI because there's some vision issues. And I think it's a time that we recognize CVI and say, hey, we're seeing CVI, maybe we should get this genetic panel and to rule out some of these issues. Or to identify, I should say, a diagnosis that really can benefit the child. Now, the final thing here, there is really little to no data on intervention. We just don't know. And CVI is such a heterogeneous in terms of etiology, it's been hard to really define if early intervention or glasses is a type of intervention, refractive error correction, early intervention in terms of organizing the room spatially so it optimizes the vision that after their assessment. Vision therapy, meaning vision therapy is a big word, and it means a lot of things to a lot of people. But what I mean by vision therapy is PT/OT vision therapy, not developmental optometry vision therapy. And I'm not going to get into that conversation, but it's really focusing on body movement and vision, spatial, doing tasks that are both cognitive and physical therapy tasks. And when we looked at that, we had 249 patients. 209 of them did not have any therapy on initial presentation. Of that, with 1 year follow-up and 2 year follow-up, we lose patients, and so that got down to 149, and then we got to 57 at the 3 year mark. Still 57, if you look at studies of CVI, thank you. Somebody's pointing it out. It's hard, actually. This is hard to get every slide, because I'm so excited to just continue to the next thing, This is tough. So, there we go, right? So, looking at vision intervention, we're on the right slide here, right? Okay. Like I said, there's overall was 249. 209 didn't have any intervention. And when we looked at intervention of the 57 who got intervention, we had to group all our intervention together because it's such a diverse etiologies that are causing CVI that anything specific like refractive error correction or like vision therapy, as I described, or early intervention had positive trends, but were not significant. But when we put them all together overall, they showed significance. This is one of the first datas out there that really suggests that intervention does help, right? So I would do it. There's no hesitation in it. There should be it doesn't really help. I haven't seen any difference. No, it helps. It does, right? Even if you're not seeing a difference, it's making a benefit that you may not see, that may be either subclinical or maybe subthreshold from you seeing, but it's definitely having an impact. And so, a couple things for moving forward from what I just showed in that data. CVI, to me, is a neurological, neuro-ophthalmic disorder. It really needs a good neurological and a neuro-ophthalmic exam. And this includes pediatric ophthalmologists who specialize in CVI. So while that paper may have a great letter from Dr. Schraff and Dr. Edmond about it, if they're not familiar with some of the stuff on that paper, they're not going to recognize it, and they're going to feel uncomfortable about it. And there are already questions from several people about showing that paper, but if they're not used, they're just getting sort of different. Every exam was different feedback, like something's changed, right? So I think it really gets, if you get to somebody who feels comfortable, you're going to get all the answers that you need that we can give during that exam. And then the other things is to understand neurological and neuro-ophthalmic findings can really color CVI. I have to go to my, thank you. Take home, there you go. There are my take home notes. Understanding the neurological and neuro-ophthalmic findings can really color the CVI assessment. So understanding if you have a seizure history, understanding you're on multiple medications, how you assess that child for vision that really plays a role, right, for their overall potential. And then intervention helps, and I think moving forward, I think understanding that intervention helps, it really can help with hastening or getting and not delaying diagnosis, and really categorizing patients so that they get the right therapy. And so moving forward from understanding intervention helps, I want to talk to you about some of the future directions that we're doing at Cincinnati Children's. I fortunately moved to a place which has a rich history of being involved in cortical visual impairment or cerebral visual impairment. So there's already established a multidisciplinary approach, and we're really forming now with sort of the several additions that we've done in the last 2 years of really a multidisciplinary approach in terms of a very holistic approach to, thank you, a holistic approach to get to assess CVI. So now we have an expert ophthalmologist with who's given many talks about CVI, Terry Schwartz. We have optometrists who are interested in CVI. We have a vision PT/OT rehab OT person, Karen Harpster, who's given multiple talks on CVI, and that's what she does, that's what she sees. We have a neonatology for early screening for CVI, a neuroradiology group that's involved, neurology in terms of CP assessment for CVI, and a big center called the Anderson Center for Development, low vision services, and now with neuro-ophthalmology, since I've been there, we sort of going a little bit further, so we are looking at the neurological exam for these children, and so the vision attention is a really important indicator of what kind of vision function they have. So wherever their attention for a child is, you can tell a lot about their vision function. And so we can sort of exploit this understanding of their vision function and their vision attention by looking at their eye movements. And so there's been a number of papers now that have come out, and I'll make sure I'm on this, that have come out and to see if we can use eye trackers to really get an understanding of where a child sees and how they interpret the world. With CVI, they're interacting with the world, but they may not be able to express it how we would like them to express it, right? So they're processing the world on their own terms, not on the terms that we want them, right? We sort of want to gauge everybody on our litmus paper. And so that's a really important understanding for CVI. So eye movements can tell us so much information about how they react to their environment, right? And so it really talks to you about what they're focusing on, what their attention is, and what they're taking from their environment. You have both intentional, how they look at something, but also reflexive. So when something pops up, if they're going to have a reflexive eye movement. And so we can exploit this by putting stimuli and really tracking their eye movements and understanding if we can develop a form of nonverbal communication with them as well. So there are many things with the eye tracker that we can do, and we have an ocular motility setup at the moment where we can look at saccades, how they actually reflexively move to a target that we present to them, how they follow things, how they track things, how they converge on things when they look at items. And then we can also how they fixate on something for a long time. So if they're really enthralled at something, how long are they looking at that? How long is their attention fixated on a particular object? And so there are multiple ways we can do this eye tracker. This picture here, which shows, we don't use, I don't use the one with I just shown you an example of an eye tracker, which is the one on the head. I think that's a little bit intrusive for any child. So, but that would freak me out a little bit. So, but the one we use is actually the sort of desktop, sort of away from them, enough so that the imaging, they're enthralled by the screen. Sometimes if it's too far out, they'll lose interest, and so we really want it close. And what we've seen benefit-wise for kids with CVI is that it has helped in many ways. It's really described function of their vision processing. We get an idea where they're fixating, how their eyes are moving. It recognizes their gaze selection and where their field of view preferences are, if it's lower or higher. It can be a form of communication for CVI patients who are not verbal, and they can use the eye tracker to actually communicate. And it really can describe neuroplasticity from a CVI standpoint. And Dr. Edmond had mentioned some of the discussions of why the vision seems to have gotten better, to some degree because of the neuroplasticity. And so we can really get a better idea and see that happen as they perform tasks on the eye tracker. And it really can also help us with understanding comorbid issues like nystagmus. When previously mentioned, when the pallor or the atrophy is so significant for an optic nerve that you can have an ocular destabilization called nystagmus that can develop. So, and going to that, you can, sorry, I put that up screen. That's what I was just mentioning for some of the benefits. And then this is a picture of how you can actually measure the nystagmus. And so nystagmus, you can actually define it, what kind of nystagmus they have, and think about interventions for improvement for nystagmus as well. And then you can really look at the neuroplasticity in children in terms of now there are more complicated stimuli that are 3D stimuli, and seeing how and where their attention and where their focus is and where their issues are. Actually, if they're walking down the hallway, if they're not seeing a particular area or area of focus, or they lose the ability to process particular areas in their environment. So I think that's all I have. I think it's time too. I want to thank you guys for letting me be part of this and giving you guys a talk. I'm here for the day, so just if any questions that come up. I think I'm going to add on to two comments made earlier, both by Dr. Schraff and Dr. Edmond, and I agree with those statements. But one other thing I think that's really important to think about when people are saying that they see their child sort of improve in vision is that there's a normal maturation for vision development that we see. You're born, a normal child's born with 2800 vision. They're not seeing things. They're sleeping more than they're awake the first 3 months of life. They're defining edges, sharps, contrast in that time period. And if you think about it, they're also more responsive to, you could be 1 foot away from them. They'll recognize you at 1 month of age. If you're 2 feet away, they won't recognize you. So there's an expansion. So there's a normal maturation in vision development. Most kids don't get to 20/20 until about 3 to 4 years of age. So I think there is that maturational component to think about why you're seeing the improvement that you're seeing as well on top of that. So, and that's just normal, right? And so what you see is that vision is two things, as mentioned before. It's acuity, but it's also field. And so if at 1 month you're only noticing things thus far away because of refractor or just normal development, you're just seeing things here, you could be 10 feet out, that newborn's not gonna notice you're there. They only notice you in that 1 foot margin, And then what you see is at 6 months that you could be 10 feet away, they won't know you're there until you walk from across the room, and you get to about 10 feet, they notice that you're there, right? And so because there is this sort of expansion of their vision. So there's an expansion of their vision, and then there's a increase in acuity, right? So their vision goes from 2800 to 20/20 over the 3 or 4 years of life. So that's where, that might be also the other aspect to why you're seeing an improvement in their vision. Early. Cool, I'm open. I'm here. Any questions? Yeah, thanks. Oh, sorry, my last one was that. My last screen was that, sorry. Yeah. Was that that's yes, it's over, it's ready for lunchtime? Yeah, okay. That's what happens when you I've given talks before, but if you're the talk right before lunch, it's the tough one. It's the tough one to get because it's like everyone's getting hungry, so.
Thank you. I loved it because you did a lot of explaining up there versus what we're seeing on the slide.
Yeah.
It really helped to understand it, so.
Yeah.
Right? Yeah, that was great, thank you.
Sure.
I'm going to speak into this so our people online can hear me. We will take a question from the audience, and then we'll go to a chat. And if you, again, have the option to come up, or if you just want to say it, and then I'll put it in here.
My question is, so our children all have developmental delays, obviously. So you mentioned that a typical neurodeveloping child by age 3 or 4 is when they would reach 20/20.
Yeah.
So could we expect to also see a delay in that?
Yeah, I think so. Yeah,
Can
I
we
mean,
stop
because
for just a second? I have to, I'm going to repeat the question
Oh,
for
excuse
the
me.
people
Yeah,
online
yeah,
so
yeah,
they,
sure.
so
Yeah,
they know.
sorry.
So the question was, if children are expected to achieve 20/20 by 3 or 4 for our BBSOAS kids, will there be a delay in that as well as far as potential for 20/20 vision? Do I have that right?
And I would say yes. I mean, one of the slides that were up with Dr. Schrapp was talking about motor milestones, right? And it was 30 months, I think, for walking, which is in normal. It's usually 12 months to 10 to 12 months in terms of walking, or 13 months. Oh, there you go. Okay. And so, so I do think there's a component of that where there's the delay potentially. I don't think there's any changes, as was mentioned before, about the hardware, which I think if you think of it this way as a hardware and software issue, the hardware, which is the nerve, how it was impacted or affected in terms of the atrophying pallor, it's a development issue, so it was a lack in it while it was developing, but it's not a neurodegenerative issue, as Dr. Schaff had mentioned. And so what you see is just pure stability in that, and then what you're seeing either cortically is the plasticity that you're seeing with what you got. And the brain is amazing. The brain does amazing things with what you got, and it does it quick, and it does it fast, because what it knows about vision, as mentioned previously, and I usually say this to my patients, that human beings are visual beings, and so much of our brain, as I think Dr. Edmond had put a number on it, 65%, but much of our brain is devoted to vision. Not only seeing, like in terms of afferent or sensory, but also motor-wise, in terms of controlling the eyes, and so that way someone can run and fixate on an object with both eyes. So you're fusing, you're looking at something, you're moving, nectars. It's very complicated, right? Because there's a lot of vestibular function, balance, control, and fixating. And so a lot of our brain is not only for controlling motor aspect, but also the sensory. And we sort of see that because we see the nystagmus that can be disruptive to vision. And then when we can address some of that, we can optimize the vision in terms of its development. Yeah.
What upcoming research do you have planned for CVI and specifically for BBSOAS impacted individuals?
What was that first part of the question?
What research do you have planned specifically around
Research? We have a couple things, because I think one of the main questions that always comes up with CVI is what's validated. And so there's a lot of papers out there on this eye tracking. I think the real interest right now is understanding if things can be validated, if things can be screened early, in terms of defining CVI earlier. I mean, 14 years. I mean, CVI was probably noted, was there all along, right? And it just was, why did it take 14 years to get that diagnosis? And I think there are research going on right now, both in Europe and in America, about what can we do for early screening. And so that's why if you saw that list that we had there, we have active neonatologists who are involved in this, because they want to know what are the vision outcomes. Is there something we can do to identify it early? And if we can identify it early, could we get them the intervention early, right? In terms of any of the intervention that we can offer them. So not only would it be identified early, diagnosed early, intervene early, would that pertain to a better outcome, better point in development for that child? Oh, yeah.
How do I know if my ophthalmologist or
I'm going to state that question again.
Yeah, sure, sorry.
A question from BBSOAS mom. How do I know if my ophthalmologist or even maybe a neuro-ophthalmologist is familiar with CVI? How do I gauge that?
Yeah, that's a hard one, I think. I think just be frank and just to ask them, directly. I think the other thing is, what are they doing for it in terms of addressing it? And I think they should have an individualized education plan to some degree. I think they talked about that. It's a state eye report mentioned earlier, but they should have. If there's CVI, you're talking about diagnosed CVI, right? No. Oh, just to assess. Yes. Okay. Yeah, I think that's. So I think being frank and talking to that individual, him or her ophthalmologist, about are they familiar with it? Do they see a lot of patients with it? Would you, if they are, and I bet you have the best at heart for your child would you recommend that I go somewhere where who have a way to get assessed, or how do you feel about assessments and coming then with plans that you have? I think would be forward thinking. And I think and I applaud that whenever anybody comes to me with that information. And many times I'm giving the diagnosis. I just know that they've been told. There's a hint of it. The families know about it. They've been sort of told about it by their ophthalmologist, him or her. And then I'm just saying this is pretty clear. This is what it is. So then once we get it, then I can get them streamlined to the other services that I've listed there, to our CVI service, to our PTOT, to really get clinical exam, to really see where they are in terms of their overall vision assessment. Yeah.
Once again, if you have any questions, please let us know what they are, and we will do our best to get with Dr. Shah and have them answered over the next week or so, next few days. And also, real quick before I forget, the presentation, some of you are asking if you can have the presentations. We will be meeting with the speakers to determine if and how much of those presentations we can have, out of respect for their information and so on and so forth. So we will keep you all posted on that. And, well, I'm standing in front of you, Dr. Shah.
No. I just wanted to thank you again for allowing me to speak. I really enjoyed it. So I'm glad to see everybody too.
We just wanted to thank you so much, Dr. Shah, for coming and speaking and being on our scientific advisory board. We have some exciting things coming up in the future. Mom's the word, so I can't say anything. But we have some exciting projects with Dr. Shah coming up, and we're so thrilled. So thanks again for coming and for speaking.